Yes, direct vision I already used in 1999 for epidurostomies. And for epidurostomy, some fiber optics were developed. And there was a company in Germany. And these are the hands. These are the hands of the CEO of that company. It was polydiagnostic. There I got familiar with this kind of technology and fiber optics and the possible potential use with the technology advancing much more. We could make fiber optics, not me, that I'm not involved. But fiber optics could be obtained that would go through a small camera. So as you see, it all starts a little bit difficult maybe because I was there as an anesthesiologist when they did the first laparoscopies for sterilization. And now they are doing total colectomies and you name it with scopic procedures. So this is a development in the ultrasound. And now I say it's ultrasound with endoscopy, so use it. And the former speakers, they have pointed out exactly what are the good reasons to do this. It's an add-on. This you already saw. So this is the Eventide 7-star. It is basically a very simple system, easy to use. Tableau, for example. So, in many cases, it could replace the CR, which is of great value because it's not easy to have the whole hospital setting with radiation, protection, etc. going to the theater. So you could use ultrasound now more safely in the outpatient clinic. There are some developments, of course, new for different approaches we use, and developed different cannulas. This is some detail you can see here a line. Normally, when you go in the dense tissue, for example, the muscle, you can imagine that the tissue might enter into your needle, and that gives a blurred vision. So we use this in some occasions to have saline infused a little bit, only 2 mils an hour. It's just to keep the pressure in the cannula, to prevent the tissue coming in. It's expanding fluid also, because you have to look forward. Applications is the added value also. It's not only replacing the CI, but of course you cannot with ultrasound, you cannot do any treatment. Now here she this is Professor Risk, already showed us yesterday. Very nice interforaminal approach. Here we see the intercostal nerve, for example. Easy to approach. Here's the nerve. You can see the longitudinal artery on the nerve. So, paravertebral blocks. Doesn't work. Okay, just leave it. It's time, but you can see the blur, and of course, it will prevent that you get some trouble with the limb collapsing. Sciatic approach. This is the cadaver. Also, celiac plexus block. You can see it here. You see the celiac artery. Of course, you need to recognize the picture. So but it is a steep learning curve. This you see already from Professor Chai this morning. This stellate ganglion block. And you see what is happening. If you go into the ganglion, you don't see what you expect, the 3 branches. But what you can do is, next to the fiber optic, you can use a stimulating RF probe. And with the direct vision, you can, let's say, see if this is connected to the first branch, the second branch, or the third branch. So you can put a stimulating procedure. You need a little bit outer side cannula, about 18 gauge. So for the patient it is a little bit less, maybe a little bit more uncomfortable, and you have to anesthetize it more. This is when I put in a catheter epidurally. This is the very diamond-like epidural fat. And I tell you, when you do, for example, giving birth, we use the catheter, yes, without direct vision. But there is always a risk that the veins who are dilated because of the birth of the child, that you puncture that. And when you go to the theater for thoracic surgery, 4 out of 5 thoracic epidural injections are okay in experienced hands, but there is always 1 out of 5 that, although the doctor says it's very accurate, it doesn't fit. You don't even use the loss of pressure. You know, you loss of resistance, you don't need. You just advance the needle, and this diamond-like fat will enter when you see just a white thing, that is the ligamentum flavum, And then you push forward, and this will come into your needle, and you can see it, then you are there. So it's a totally other concept. Lumibird back to me. This is a little bit difficult to interpret, to see the lumbar sympathetic. It is somewhere here. Here it is. But I couldn't let's say, take the image of the ganglion. Yesterday I showed you the cordotomy. You don't have to use saline in the cordotomy because you have the cerebrospinal fluid, so you can see it very well. It's for single-sided cancer pain, cutting the spinal thalamic tract, which is still a little bit, doctors are reluctant to do this because it's a spinal cord lesion, what you are, in fact, produce. Because the spinal thalamic tract is in front of the dentate ligament, on the ventral side. If you go here with your RF probe, then you have a paralyzed patient. So you don't want to be motoric. And this is what you actually see. Here is the probe, the RF probe. These are the radix radici, the ventral root entrance on the spinal cord. Here is the dentate ligament. You want to be on the ventral side, on this side. And here you see it in real time. You see the pulsating of the heart. You see a little clot here with the pulse of the heart going up and down. This is the electrode. Here is the dentate ligament. And now I will draw the needle after 20 seconds or so. You see a small hole in the needle. And then you do the normal testing. Tracheotomy, for example. We lost a few patients in the Netherlands during the COVID period by accidental, incidental decubation in the overcrowded ICU unit. And then you have to do an emergency tracheotomy. And you have a default route. The patient is already swollen and it could be very difficult. So with this technology, you just push it between the cricoid, thyroid, and you see the tracheal rings, you put in the guide wire, dilate, put in your device. Have to go through. It's also used, of course, in the outpatient clinic. It is easy for orthopedics, that's another discipline, but they use it just to diagnose and to put some small treatments into patients. Without, of course, radiology, without CR. This is urologist. Diagnosing, using it for kidney, for biopsies, but also on the liver. If you have a carcinoma, it's very small metastasis, which is more, then it's difficult to see on the ultrasound, where you exactly can do your biopsy. So new horizons. Already the former speakers. Increased accuracy, safety of injections, procedures, maybe better outcomes, provides the invisibility and accuracy of ultrasound, guided procedure, no steroid radiation, and it's cost effective because you don't have to use the whole hospital setting. And of course, forensic, you can record actually what you are doing, which is very important that when there is any claim or any the complication and the patient, you can also show where you were and what you have done. So this is, I think, the future. And I hope we really are going to use it. Thank you. Is that, yeah? Can you? Maybe if you start also here. Yes,
thank you for you like to interesting election. I have a question. For neurosurgeon, when you are working with transforaminal, the scope is very big, okay, and view is very big. Okay, here you are use very small cannula, and vision is very small, few millimeter. If you are far away, 2 or 3 millimeter, you are lost from the structure. Even you are use fluoroscopy, even use ultrasound, and the structure is very difficult to differentiate. Okay, and camera, use straight camera or 30-degree camera. What type is very difficult, okay, to work intervention or remove part of the disc or remove. It's very difficult. Okay, what your experience is this?
Totally agree with this. For example, the transforaminal approach is the big target for us every day. Many years ago, my target is, if I have ultrasound, obviously we working before with X-ray with contrast for to identify or maybe CR or maybe MRI. But after when appeared the ultrasound, I want to identify the same space in the for transforaminal access with normal ultrasound passive, B mode and Doppler. But it's, for me, was insufficient. And I prefer combine the advanced ultrasound with 3D, 4D, and flow Doppler and elastographic. You has we have a big problem with this. It's true that it's a little hole, and with the microendoscopy you have the possibility to look the hole. But when you put, for example, volume inside of the foramen, you have a big problem in the adjacent areas because you don't have the control of the pressure that you put in this area for the vessel, for the artery, and for the nerve, and for the rod. And for this reason I use in my habitual practice the elastographic quantitative shear wave to calculate, to measure the degree of tension of the hole. This is in kilopascal and meters by second. Shear wave elastographic. I don't pass the light, the micro camera, inside of the hole. It's only for to look. I combine different devices: X-ray, advanced ultrasound, and microendoscopy. Remember that is another tool for increase the security, the safety for the patient, and the best result for us. It's my opinion.
As we discussed yesterday, we're not doing surgery with this device. We're just looking inside. We're not doing surgery. You don't need to look for the disc. You're just estimating the stenosis inside this foramen. Once you see the pulsation, you're there. You don't need more.
If you want to
we're injecting. 1 minute, please. Excuse me. You need to inject. We need to inject in that foramen. We're not doing surgery. We're not taking the disc out. I don't care where the disc. Once I see this pulsation and I bypass the intertransverse ligament, there's no way to be confused because you see the intertransverse ligament and you're bypassing the intertransverse ligament. And once you bypass the intertransverse ligament, you're in the foramen. You should look for the artery. And I showed you yesterday, once you see the artery, you need to inject, and the diffusion of the mixture will go epidurally. I don't care about the disc. I'm not looking for the nerve. I'm not doing surgery again. I don't search in the foramen. I'm just looking inside the foramen. This is what I'm doing, to increase my safety and accuracy, to be sure that I'm inside the foramen and I'm not injecting in a vessel or a nerve. Okay? Go ahead, please.
If you do, as you do laser, okay, laser, you do intervention. You not do for diagnostic only, you do for intervention, not diagnostic. You don't use the camera to see the structure. You want to do intervention, laser, annuloplasty.
Laser not for transforaminal
Not
approach.
for transforaminal.
No, laser for caudal approach, not for
I
transforaminal
ask
approach.
about the other approach and not speak now about laser only.
Okay, okay.
Okay. I not speak about transforaminal. I
Okay.
speak about all
Okay,
the approach.
yeah.
Yes.
Because transforaminal is just for injection, you
Yes.
don't do intervention.
Yes. Other approach, you are use intervention. Other approach. How to differentiate? How your safety? The problem is your safety. The problem when you are using transforaminal endoscope and the bigger scope, many times you can differentiate between the nerve and this. It's very difficult, and you have very wide area, and here is very small area.
Yeah, I know.
You're right. We did not reach nowadays with this scope to differentiate. We don't care about differentiating. We're just looking for injection. That's it. Okay? We're not yet doing surgery with this device.
If you are far away from the nerve, 2 millimeter, you can differentiate. You can
Yeah.
differentiate.
We're not discussing this issue, but we're not looking to differentiate.
We totally agree with you in this part. No, it's perfect. It's a little off.
Okay.
It's no problem. But it's to see. Remember my slogan and our slogan with this machine. To see or not to see, that's the question.
Sometimes
It's
you
only for
not
to
see
see.
anything. Sometimes you not see
Exactly.
anything. It's okay. Thank you.
Are you convinced?
Are there any other questions? If there are no other questions, then I suggest that we go on with the afternoon session. Maybe we have a short break for you, go to the washing room or whatever. So in 5 minutes, is that okay? Okay. See you in 5 minutes.